All right, so today we're going to talk a little bit about lower back pain. And in my career of working with patients with lower back pain, what I've found is that while lower back pain has a lot of causes and a lot of different presentations, you can have discogenic pain, you can have facet joint pain, you can have muscular spasm. What we found is that lower back pain is actually kind of a lot easier to treat than a lot of people think it is. So we're going to break this down into a couple little segments and first find out why we have lower back pain. Now, I'm not going to teach an exam right now of how you find lower back pain, but just know that you're going to do orthopedic tests, you're going to do functional movement tests, and you're going to do palpatory findings and your standard neurologic assessment. When you do all of these things, what you will then determine is what's the cause of that pain. What is the pain generator? Once you determine the pain generator, you then can determine how to fix that pain generator and have it go away completely. So, generally speaking, in most people that we see with lower back pain, the number one thing that people start to give in terms of exercise for that are core stability exercises. This is the first thing we hit with core stability. We give people dead bug or abdominal bracing, then dead bug. We give them bird dog. We give them stuff that we think is going to help them to stabilize their core. Well, what if I told you that in most of the people we see, whether you're seeing athletes like me or you're seeing everyday office workers like a lot of other people out there, what if I told you that most of the people that we see with lower back pain actually don't have core stability problem as their primary problem? What we tend to see is that people tend to have issues more in their thoracic spine and in their hips. So specifically for men, let's talk about men for a second. Men will often have a very hypomobile thoracic spine. Thoracic spine does not move very much, specifically into extension and rotation, which is when we see this hunched posture, what Dr. Yanda would have called an upper crossed syndrome. We see this tight and restricted thoracic spine. Then we also see down into the hips and the pelvis, we see tight and restricted hip joints. We'll talk about the SI specifically and the actual acetabular-femoral joint. It doesn't move very much. When these joints don't move, your acetabular-femoral joint, your SI joint, and your thoracic spine, when none of that moves very well, what do you think the lumbar spine starts to do? Well, it says, well, you still want me to move, so I'm going to move from here. And it starts moving more than it should. It compensates for a lack of motion in the thoracic spine and a lack of motion in the hips and pelvis. So it's taking over because the body is very adaptive and it says, I know that you want me to still bend over and pick something up. I know that you want me to twist and rotate and do all of these things, so I'm going to take over. Well, the lumbar spine is good at flexion and extension, and it's good at lateral flexion, but what is it not good at? Rotation. It does not do rotation well at all. That should be in the thoracic spine and in the hips. So the lumbar spine takes over. So when we start to address people right away with core stability exercises for their lower back pain, in my experience, we're missing the boat and we're going past the original problem and we're skipping ahead. So we're trying to stabilize something that has decided it's not going to be stable because it wants to be mobile so it can live and you can live like you want to live. So let's talk about some ways to gain mobility in the thoracic region and in the hips and pelvis. So first of all, Kelly, if you can get quadruped on your hands and knees. So one exercise I like to do is what we call a quadruped thoracic rotation. What she's going to do is she's going to take her hand and put it on the back of her head. From here, I want her arm stacked right underneath her shoulder. From here, she's going to drop her body down, just creating rotation in the thoracic spine, and then she's going to rotate up, like so, keeping her hips and lower back stable, and then back down, just in the thoracic spine. I can use something like a CLX or a stretch strap to also come in to her shoulder here and I can provide a little bit of overpressure. So I can try to get a little bit more motion out of that. This is good for those that are particularly conscious about getting close into the chest on a female patient, or anybody else that doesn't like to be touched that way. But ultimately, providing this overpressure here with my hand where I'm stabilizing the spine and I'm either coming with my hand or with a strap can really help to create a nice assist into that thoracic rotation range of motion. If I find that the patient is doing too much lumbar spine, we're gonna have her sit lumbar lock. So put her butt on her heels, back into the same position, just on your forearm now. Yep, hand on the back of the head. I've now locked this lumbar spine. She's gonna do the same motion down and up. And now I've really stopped this lumbar spine from creating excessive motion in what we're doing, and I'm just getting this thoracic spine movement out of here. So that's one. The second thing we'll do right from this position is take that same hand and put it on her lower back. So she's gonna put it like that. Same thing, she's gonna come down and up. And what patients will do is they'll feel this in a different spot of their thoracic spine. Most people will feel this a little bit lower, some will feel it higher, most feel it a little lower. Go back down, where do you feel it? Lower. She feels it lower. Go ahead and come back up. And again, I can provide this overpressure. So what I'm doing is I'm getting thoracic rotation, a little bit of a self-mobilization, a self-stretch. This is an active stretch, it's not a held stretch. I don't have her hold it for 30 minutes or 30 seconds or anything. I'm just having her go back and forth to move regularly throughout that spine. So that's the first thing we like to do for thoracic rotation. When we get into thoracic extension, turn around and put your hands on the ball. We can do a couple of things here. So she's gonna do something that we often call a prayer stretch, where she's gonna roll this ball out and she's gonna drop, actually slide back in a little bit so we don't hit the camera, the tripod, there you go. Go ahead. She's gonna roll out and she's gonna drop her thoracic spine down. Can you bring, so keep your hips up and drop this down. So roll the ball out. There you go, good. All the way, no, roll it out. Hold on, come here, come back. Stack your hips and just roll your upper body. There you go, yeah. So now she's gonna drop this thoracic spine. When she drops this thoracic spine, she can get a stretch. What we wanna be careful of is not getting the stretch only in the latissimus. So if she feels this only here, she can bring this ball closer to her and then drop more, eliminate that stretch of the latissimus, go right to the thoracic spine and try to get a thoracic extension stretch. So now she's just getting thoracic extension. So this is something that can be done on a bench, it can be done on a table, it can be done on a ball. Good. You can use a foam roller and roll out, ultimately trying to get this to drop so that we get a nice thoracic extension stretch out of this. Okay, come back up. And come onto your back. There are lots of ways to do thoracic extension and rotation, mobilization, and stretches. You can do them against the wall, something known as a wall angel, where you're raising your arm up, something we call a standing jack, which is to stand against the wall, head to sacrum, all touching the wall. Raise your arms up overhead, keeping everything in touch, and try to touch the wall. You get a little bit of latissimus out of this. Anytime you want to lessen the latissimus, just bend your elbows and drop your shoulders a little bit and still go up, and you'll get more thoracic spine and less latissimus. So lots of ways to do thoracic extension, rotation, mobilization, stretches, and you want to continue to do those. Now let's talk in the hips. One thing we see in people with hip mobility issues is we see something known as active insufficiency. What that means is that they have more range of motion than they can actively access. So if you rotate your leg out like this, so she's rotating into internal rotation. She has, whatever, 35, 40 degrees of internal rotation, but I can push her further into internal rotation. She has a lot more than she can access on her own. So what we like to do is we like to do kind of a mobilization strengthening. It sounds a little bit odd, but what we're gonna do is we're gonna strengthen the internal rotators to be able to gain more internal rotation. So Here's what we're gonna do. Put your feet up like so, both of them. I'm gonna take this CLX band, which has continuous loops in it, and I'm gonna put them around her feet. So now I've just created a resistance between her feet. Take your hands, put them between, yep, like that. So now we get a nice spread. I want your hips right, your knees right over the hips. We get a nice spread here. I don't want you to let this come apart. From here, keep your feet high where they are and just push them apart. Good, and then back together. This is called windshield washers. Keep your hands together. Keep your hands together, good. It's not about speed. So this is windshield washers. What she's doing is she's doing a bilateral internal rotation exercise, keeping her knees together. This is pure hip internal rotation, and she should start to feel fatigue in the internal rotators in her glutes, right? So when she's doing this, she is getting and helping to gain more internal rotation out of her hips. Great exercise for internal rotation. Tired yet? Okay. So you can advance that. You can do that any number of sets and reps really that you want. I like to do things sometimes to fatigue. So I get them to a good burn of the muscle, do that. Maybe it's 15 reps, maybe it's 20 reps, but get a good burn out of that muscle and then have them relax, have them come back and do it again. And I do 2 burns normally to start. That's a good way to get these muscles working and get them started. So we have a nice internal rotation for the hip exercise for strengthening / rotation. Of course, with the therapist, put that straight. You can always do some internal rotation stretches from this position. Notice I stabilize her knees so that she's not rolling out. You can do things like that. I just prefer them to do a little bit more active stuff. I don't like them to sit there and get a lot of just passive treatment by me. I do manual therapy, I do manipulations, I do hands-on treatment with hot grips, I do dry needling. So when I do all of that, the rest of the time, I want the patient to be actively involved in that, not having stuff done to them, but rather having them do stuff. It makes a big difference for them. Okay, so stand up. So what we have now is we've addressed some of the thoracic extension and rotation issues. We've addressed some of the hip rotation issues. So all of that hypomobility, we've addressed that. Now let's get to the point to where we say a couple of weeks down the road, our patient's pain, I don't know that I really care about it right now because I'm trying to fix the cause of the pain. So if it's better, awesome. If it's not that much better, okay, we'll move on. And the reason I say that I don't necessarily care about pain is the funny thing is that patients don't care about pain either. I always say the dirty little secret about pain is patients don't care about it. They care about what pain doesn't allow them to do. So what our goal here is to resolve the cause of that pain so they can get back to their previous levels of functioning without pain, and that they can do all the exercises, all the life that they wanted to do before. Patients don't come to us and say, oh, my pain was a 6, now I'm coming in. It used to be a 5 and I didn't think it was that bad. They come to us and they say, I can no longer play with my children, run, go to the gym, drive my car to work without having pain, whatever it may be, their choice. They get to a point to where they just can't get there anymore. And that's why they come to us. So we are at the point where we now have good thoracic mobility, or better anyway. We have good hip mobility. So we can start to work on our actual core stability exercises. Because what you'll find is that once you create motion in these thoracic region and in the pelvis and hips, the lumbar spine stability will become more prevalent as being unstable, and we'll need to provide more stability to it. So we can do a couple of really easy things. First thing I like to do, interestingly enough, is I like to put people in single leg stance. You're gonna take your shoe off because we always do single leg stance exercises without a shoe. But what we know is that the highest receptors of sensation in the body, the most amount of proprioception coming into the body, come from 3 spots: the sole of the foot, the sacroiliac region, and the cervical spine. That's where the most input comes into us. So what we want to do is we want to get people to be able to re-engage that sole of their foot. We want to get people to be able to re-engage their pelvic muscles so that we can get the most proper information coming in about the world around us. The other thing that we see in people with lower back pain is that if you remember those strategies, balance strategies that we have. So we first have the ankle strategy, and then we have the hip strategy, and then we have the step strategy. So if you think about when you perturb someone's balance, that's what they do. They first start to create stability in their ankles. Then if it's too much, they move into their hips. Then if it's too much, they actually take a step to catch themselves. So in people with lower back pain, their ankle strategy is actually less. They don't use it very much anymore. They bypass that and go right into the hip strategy. So they start to automatically stabilize here, which puts a little excessive and extra range of motion movement on their lower back that their lower back doesn't want. So we train people with lower back pain in single leg stance. We do a lot of it. We get them to re-engage that ankle strategy. We get them to re-engage the amount of information coming in from the sole of their foot, all the while keeping their pelvis stable so that their glute max and their glute med is active and transferring that energy into the core. So we'll just have them do a simple stand on one foot. I like to get that foot up to at least 45, 90 is fine. I don't like it behind. It cannot touch. I don't want the hands on the hips. I want them down. I want them stabilizing. So she's pretty stable in this position on a blue stability trainer with her eyes open. Relax. We will progress people in balance exercises first standing on a firm surface with their eyes open. Then they stand on that firm surface with their eyes closed. Once they move into balance stability in unstable surfaces, you actually move them through the progression so that they go all the way through eyes open, and then you come back and go all the way through eyes closed. We rely so heavily on our eyes for balance that we need to do these first. So we would be on a green stability trainer. Thank you. Green stability trainer, followed by a blue stability trainer, followed by an air-filled black with texture, because that provides more information to the bottom of the foot that gives us more ability to stabilize, followed by flipping this over into a non-textured surface, air-filled, and then ultimately into a wobble board. All with our eyes open. Believe it or not, we have more instability standing on a foam pad with our eyes closed than we do on a wobble board with our eyes open. So we move all the way through. So she was pretty good standing on the blue stability trainer with her eyes open. She did pretty well. She didn't have a lot of balance problems. She was able to be there and hold on to that. So we can progress her then into black with the textured surface, hold that and make sure that she's able to maintain that for 25 to 30 seconds. And then we move on. Black without the textured surface, wobble board, and then we come back down to eyes closed. That's all static balance. We can also, can I see this yellow ball? Good. We can also incorporate a little bit of dynamic movement using a soft weight. So here's a small weighted medicine ball. So come on to one foot on the blue. And what I like them to do just to start is just pass this around their body. So she's going to hold it, she's going to pass it around her body. This is a small weight, it's a couple of pounds. We can move up to different weights. We can move to red, green, blue, black. We can move to different weights so that she has more of a disturbance around her body. This starts to incorporate a little bit of movement and a little bit less conscious activation on, I'm standing on a stability trainer, I need to stand upright. Okay? So this is where we start with single leg balance. The other thing that we've found is in our research at our research facility at the Sport and Spine Rehab Clinical Research Facility, we have found that people with lower back pain have a significantly worse activation of their glute max muscle. Their glute max does not work like it does in the healthy population. So we need to be able to re-engage that glute max. We think that the glute max working better will create for more proper hip extension, which will eliminate the need to get into lumbar hyperextension when trying to ambulate or trying to do anything that requires hip extension. So come down to your hands and knees. The number one exercise that we found for gluteus max activation in the low back pain population was something known as fire hydrant exercise. So what we're going to do is we're going to take a loop, put it around her foot. We're going to take another loop and put it in her hand. No, thumb. Good. And then go back down. I love to use the loop into the hand here so that it's stable, it doesn't slide. She's got good control over it. From here, she's going to do an exercise called fire hydrant because it looks like a dog, a male dog urinating on a fire hydrant. She's going to come back, out, and up. So it's a combo movement. Back down. The movement is not to the side, it's not behind, it's at an angle. So come up and out, good, and then back down. Now, I want this to be nice and stable. I just want hip motion, come up and out, good, and back down. So she's gonna stabilize this motion from here. You do a little bit more extension, a little bit more back. There, that's a little better. Not with the knee, the hip. Good. So we're trying to get there, that's the motion I want. So this is the motion I want right there. This band is providing resistance along there. What we find is that this is a great exercise for glute max activation. That glute max activation is going to really help with our low back pain patients. The next exercise that we like to do is called the running man. So what you're going to do is you're going to stand up. The running man exercise is where we've already progressed through the ability to do single leg stance. We've already progressed through the ability to do dynamic movements on single leg. The running man is we're going to simulate a run in this. So what I want you to do is do exactly that. Simulate this run. So this foot's up, this knee's up, this hand's up. So yep, hold on. Can you do this? Now, I want you to dig deep into a squat so that you come down and then come back up. But you're moving your arms too, good, and then back down. So you're reaching back and then up. Hold on, get your balance, get your balance. Here, let's go to this. See, this is live. Okay.
Live.
Okay. Knee up, hand up. Get your balance. Nope, that one.
We would like to thank our CSN
Hand up.
2017 sponsors,
Can you get?
Alter G, Aratech, Bayerness,
Okay.
Blue Jay.
Go ahead and switch your legs and arms.
Chapman University.
Close. Here, let me do it. All right. I've got practice. So, leg up, hand up, the opposite. From there, I'm going to come down into a deep squat and then come back up. It's looking like I'm running. This exercise activates a lot of glute max, a lot of glute med, and it doesn't involve our TFL as much. All of these things are really important in activating our gluteus maximus and getting our low back pain patients back on the road to feeling good. So you notice I didn't really go over abdominal bracing. I didn't go over dead bug. These are things that a lot of people do. Bird dogs are great exercises. I like to do these things. I like to do a lot of these things with external cueing. External cueing is a visual reminder, like a laser, that helps them to see where their deviations are. And when we do all of these things, when we first address the thoracic mobility and the hip mobility, and then we start to address their ability for single leg stance, their glute max activation, and get that to be nice and strong, and we start to do those core stability exercises that we're familiar with, Our low back pain patients are going to get better a lot faster than they were before, and they're going to stay better.
Please also
Good?
wipe your
All right,
hands.
thank you.